demon possession happens on like certain personalities,
right,
and not on the whole person. And we talked about how it's like theology assumes that a person is like whole.
yeah.
And so does that mean like dissociative identity disorder is also effectively like splitting the soul as well? Or is that like
Yes, that's what I was thinking. Oh boy. I don't know that I've gotten that far into it, quite honestly. I mean, it would make sense given the way we're describing it that the soul is split as well. I think in a lot of the cases, certainly I was a part of, it was almost as if the parts had their own kind of spiritual journey and relationship with Christ. So, I mean, from that point of view, that would be a logical conclusion to make. Like I said, it kind of blows up every preconceived notion when it comes to theology about how people function and so forth. But I mean, there's Scripture isn't a psych manual. It's not like it gives us clarity on everything. And we certainly have plenty of instances in Scripture where it talks about Jesus, exorcising a demon from a boy, and the particular part of the Scripture I was reading today, looking at it from just a purely monist physical perspective, it looks like, or at least sounded like, it was a kid that had epilepsy. But there was also the demon presence as well that kind of lurked within the kid, including the physical, it would appear at least, the physical difficulties the kid had. So, but yeah, I think that, like I said, I think that's a logical conclusion to make, that not only has the personality split, but the soul has too. So, any other questions or anything? Yes, sir. You're on a roll.
So we don't have to, you don't have to answer the question today.
Thanks for the freedom.
But, something I've been thinking about really heavily, actually, no, this doesn't even have to do with it. Well, nice.
Yeah, right. Set us up. What the heck?
Okay, how intertwined is the mind with the soul?
I thought I had a headache before. Yeah, I think at some level, even from Scripture, some places it's delineated. I mean, it's separated. Mind, strength, body, and soul versus mind, body, and soul. I don't know that how much we can make of each kind of dimension, if you will. I think from Scripture and what I understand of Scripture, the heart encaptures all of those things in some sense. So the heart would probably be closer to our word for mind than the soul would be. At the same time, I think some people would say the soul incorporates the heart as well, or enlivens it. And so when the person dies, the soul/spirit of the person leaves the body, and the heart is innervated by the soul and the spirit. So, like I said, that's probably way, way, way above my pay grade to answer for you. But my understanding has always been where mind, soul, heart are really, you really have a tough time teasing those things apart because they're so intertwined in Scripture, at least. So that's the best I can come up with. Anything else? Any other questions or anything? All right. Well, let's where we left off, I think, is the. Is it going to play well with me today or not? I showed you that video about listening, that one, and we talked a little bit about some of the skills that were a part of just the relationship development or the relational element in working with people that have gone through a variety of crises and things that they have experienced, trauma. And the idea of active listening isn't just hearing accurately. It's obviously a lot more than that. It's being able to get into the other person's world. Empathic understanding or responding really can be divided up into 5 different levels. I'm not going to go into those today, but the most advanced level of empathy or empathic responding has to do with not only what's stated in terms of the words that the person uses and the descriptions that they use, but also recognizing the affect that's underneath it, the emotional content underneath it. And then also, when I listen, I'm adding to it. I'm making guesses. I'm adding some content there for the person to use to further identify what's going on in there. What often happens when you're around or working with people that have been traumatized is that in a lot of cases their vocabulary, their emotional vocabulary gets constricted. And some of that is a defensive constriction. And what I mean by that is that they don't identify things because if they do, it'd be too frightening. And that's fairly typical when you experience somebody who's gone through just on the heels of some crisis that they've gone through or some traumatic event they've experienced. They don't seem to have words to describe it. And the person that is helping that person really is in a sense in charge of trying to help them put words to their experiences. At the front end, that may be very difficult to do. And that would be one of those places where John described just being present with the person and sitting and having them tell their story or have them tell what happened. And that's really about it. And when they're reporting like that, it's pure content. There probably is not a lot of emotion in it. I oftentimes refer to it as kind of the news reporting stage. It's like they're reporting the news. They're disconnected from it emotionally, which connects up with what Doug was talking about when we talk about disassociation. Dissociation is a severing, so a pulling away of the emotion with the story that the person has gone through. Ultimately, what our attempt to do in working with the person is to get these things relinked together. And dissociation at the extreme end is particularly difficult because of how separate the different parts are when we were talking about DID. But some of the things that oftentimes comes up that is required to get comfortable with is asking probing kinds of questions and recognizing how the person responds will tell you how much farther to go when you ask a probing question. So what exactly happened? That's the first probing question most people will ask. Well, then when the person starts to tell their story, you have a choice to make about whether to interrupt to get more detail or you let them continue, which is ventilation. All right, and ventilating is like I think I used the metaphor of a pressure cooker. The things that have been pushed in there, they've been held under pressure because the person doesn't want to hurt anybody else or spew off on anybody else. But at some point, when they're invited, they can start talking. And the ventilation point is really just getting out whatever is there. Beyond that, then, we separate out pieces of it. So once the person perhaps has told us the story, then we wind back the reel and go back to the beginning and say, now just at the very beginning, you told me, you were walking home. Let's just, because our next topic is going to be sexual assault. And you were walking home, and that's what you remember. Well, at that point, you stop at that and say, so tell me what you were thinking at the time. What kinds of thoughts were going through your head? What kind of things were happening or happened before you started walking home? what was happening at the time that the event occurred. That's called partializing or compartmentalizing, if you will. And it makes it a smaller piece. You fence it in a sense, and you look only on that. Because, in some cases, remember the A, B, C, D, E thing I showed you, there are beliefs in there that you need to at least get a hint of as to what's going on in there. In a lot of cases, people that have gone through traumatic events already have a belief system. And the challenge that you have is trying to explore and understand exactly what that is and how that actually works for the person. If you don't understand that, then it's going to be tough that when you see their reaction to what's happened, you're not going to have any context of understanding what actually has gone on in there. So on the basis of these things then, we have a different set of skills that focuses in on what we call enhanced coping and change and recovery. This is applying, all right, the ABCD model that we've been talking about in terms of crisis intervention and the environment and all the other things. So for the affective part, all right, so we're going to pull this out. So for the affective part, we're focusing almost entirely on the affective content, the emotional content the person's experiencing. So we might ask them to focus on what those emotions were. How did they feel? Was there physical concomitants that were part of that feeling? A lot of times people will have things like that physically they might feel like they've gone numb, or they might feel like their skin is on fire, or they have this premonition of some sort, or things like that are part of that. Sometimes, depending on where the person is in their recovery, you can do guided imagery. In other words, close your eyes and imagine you're back in it and describe for me what you see. Well, that's dangerous territory in the early going, because they have not gotten any sense of mastery of their emotions around what actually happened. So guided imagery is not something you do immediately, because essentially you're inviting them into a flashback is essentially what you're doing. And you have to be very careful with that, because it can be every bit as, what do I want to say? Deconstructing, if you will, decompensating for the person. That's the word I was looking for. The decompensating. And actually you invite them into a place where they don't have any skills to deal with the deterioration that they experienced when they go back through it again. So you have to be very careful with the whole idea. It is something to use at a later point in time, perhaps. The other one is, and again, these are all part of a longer experience or a longer journey in terms of recovery, is the emotional containment and regulation. Usually what happens for most people that have gone through something traumatic is it's not emotional containment at all. It is emotional suppression is what it ends up being. And they essentially think in very dichotomous terms. It's either I have it all and I fall apart and I can't function and I hurt everybody around me, or they feel bad, or they feel helpless, or whatever that might be, or I don't have it at all. And that's, again, that dichotomous style of thinking is not terribly uncommon with people, because they can't find the middle ground. And usually they have some catastrophic belief around the middle ground. In other words, if I allow some of these emotions out, see, the word some implies containment. And they haven't developed those skills yet. So you have to, in some cases, we have to actually discern at what level does the person actually have the skills to do emotional containment. With young kids, they don't. Usually they don't. They have to be taught it. And we have to understand that. You can't assume that adults, because they're adults, do. Because they don't either. There are lots of adults that I've come into contact with where they need to be taught about emotional containment as well. Because they vacillate between falling completely, quote unquote, falling completely apart, or having no emotions at all. and it's too close to comfort for them, at least for the emotions themselves to show up in any form. The other thing that we tend to do or can do, depending on the person's situation, is something called systematic desensitization. And this term probably sounds somewhat familiar. It is a behavioral intervention for people that have been through it, through whatever trauma they might have. EMDR, interestingly enough, is a form of systematic desensitization. How many of you guys are familiar with EMDR? You've heard that phrase before? EMDR stands for eye movement desensitization and reprogramming. It is very common. It is oftentimes very effective for de-escalating extreme emotions around trauma. And essentially the theory underlying EMDR is that the person is asked to follow the therapist's finger, and the therapist's finger is moving across the person's midline, and that what they're instructed to do is simply follow the finger with their eyes, not their heads, with their eyes. And what has been found is that as they report a memory in the midst of going through EMDR, it seems like the memory's intensity decreases considerably. And that tends to make some of this emotional containment possible. It tends to make processing the emotions a little bit easier. Yeah.
This might not be applicable, but like the vibrating thing?
Same idea.
Oh.
Yep, they're exactly the same. One therapist here in Colorado actually developed a light bar, and you just follow the lights as they move across, or the vibrating that, like you're describing, in your hands, and they vibrate in one hand to the other, and you focus on those as well. Sometimes they'll also have different temperatures, and they'll do warm and cold in both hands, one hand or the other. So the variations have been, some of the variations are currently have been found to be equally as effective as watching a therapist with his finger. Unfortunately, the therapist gets tennis elbow really bad. I'm serious, and that's why he developed the light bar, because he was doing this 5,000 times a day, and he said, I can't keep doing this, so he developed a bar that had a series of lights that run across, and he just turns it on, puts the headphones on, and the person watches it with their eyes. Yeah.
So is that kind of like a grounding exercise?
Yeah, it's desensitizing. And what they have found is that when the person's eyes cross the midline, so I'm holding it over here, and you look in this field, and I move it across, your eyes have to move across your midline in your brain, and it impacts memory storage and memory acquisition, or memory retrieval, I should say.
Do they do that for ADHD?
Sometimes they do. Yeah, not often. Yeah. So I mean, it's impacting memory storage, retrieval, acquisition, etc. So, and that would fit into this as well. The systematic desensitization has been around forever, since behavior therapy was developed. It is very effective. Usually what it requires a person to do is to make a series of cards that are rated according to intensity of fear or emotional content that's related to it, going from 100 down to 1, and they do them in small degradations down. And essentially what the therapist does with systematic desensitization is they start at 0, which is like being on the beach, thoroughly relaxed and listening to the waves lap up against the shore, to 100, which would be the event, the level of fear and everything else a person feels. Essentially, the protocol itself is built on the idea that relaxation and anxiety cannot coexist. And so what we do is we teach the person relaxation techniques, usually progressive relaxation techniques, which essentially what that means is we teach them how to progressively clench and then release the muscles in the body. And we start from the very top of the head, so you grimace real tightly, like that. I say it, and it's always funny how many people do it for me. You grimace, you hold it real tight, and then you let go of it, and feel what the release of that tension is like. And we'll go through the face, we'll go through the neck, the shoulders, the arms, forearms, fists, etc., all the way down the body, tensing the abdomen, big muscles of the legs all the way down. And then at the end of that, they rate kind of the level of relaxation they're at. Most people, when they get relaxed, don't fall asleep. Most people think that's the same thing. And usually what's interesting is most people will report that when they achieve a reasonable level of relaxation, they feel more alert than anything. There are parts of our body, particularly our musculature, that tend to be systems triggered by our stresses. And so whether that's neck and shoulders, a lot of people have shoulder stuff, or neck stuff. A lot of times the neck pain and tenseness in the neck will radiate up to the head and then trigger headache pain of some sort. And that's fairly typical. And some of the progressive relaxation, you can get them, you can get a protocol online and have somebody read it to you and listen to their readings, and basically follow it along, and you'll be pretty surprised at how well you get relaxed. The idea is that they maintain their relaxation while we go up in the severity of the situations. So I would read it to the person, and they would say they were relaxed. Usually we just have somebody in a soft chair with their hands on the arms of the chair, and when they're relaxed, they just raise their finger, and then I move on. And then if the relaxation starts to deteriorate, they go through their protocol again real quickly, because the longer you do that, you tend to be able to spot check parts of your body that tend to get really tense. And then you work through that and go back through it again. It is really, really time consuming. I had one nurse patient of mine who was sexually abused as a little girl, and really pretty much forgot about it. I think we talked a little bit about this with the association. And the memories all came flooding back when her daughter passed the age at which she was sexually abused. And by that time, she had gone all the way through nursing, and lo and behold, she was a maternity nurse, an OBGYN nurse. So in most maternity wards, the nurses, the OB nurses, they will do a pelvic check for women that are pregnant, that are in labor, and to check, how effaced the cervix is and so forth. And for her, it was so triggering that she couldn't do her job. And so she came to me, and we went through this systematic desensitization with these events and the triggering events and so forth. And she had one or two, the way she called them, and a lot of people do, meltdowns at work. And she went into a closet and just cried and kind of released a lot of this tension that she had, and then tried to go back to work. And so that was happening 2 and 3 times a week. And the doctors were really getting pretty impatient with her because she couldn't necessarily be counted on, particularly in the throes of a woman going through labor, active labor. So we went through the protocol, and it took me about 8 to 10 weeks to work through all the protocol with her. Did a really, really good job. I basically recorded the relaxation protocol. She had headphones. She would listen to it and get comfortable in using it on a regular basis. And by the time we were done, she had little reported anxiety at all, even on the unit or doing her job at all. It was really quite effective. And that's just an example. But like I said, it's really time consuming. I had to see her 3 times a week for 10 weeks. That's 30 sessions. And thankfully she had good insurance and good income to be able to support that. Most people can't. The one thing we found out later, and this is within about the last 10 years, is that we really don't need to do the relaxation protocol. Actually, what ends up happening is the relaxation masks the anxiety. The person never really gets challenged to try to deal with the anxiety as it's happening. And so some of the newer protocols are not using the relaxation stuff at all. They're just reading it, working with the person through the belief systems and things like that they have, and then continuing to move on with it. Some of you guys probably remember the snake-phobic woman I showed, maybe more vividly than you'd prefer. But she went through this protocol, and essentially the the guy that was doing it was the researcher that discovered this, and basically had a corn snake. And when you watch the video for the first time, you're really shocked at her response. It seemed like way out of proportion. Well, basically, welcome to phobia. That's what happens. And just through exposure over 3 or 4 hours, she was able to get to the point of handling the snake and having it around her neck and on her lap, and so it really is the innovation that oftentimes is needed, I think, for some of the things that we do with people that are extremely anxious over what they've been through. Yeah, Maddie.
I don't know if this is off track, but in light of the visual and auditory techniques that are used in the coping and recovery, what is the affective aspect of therapy for those who are blind or deaf?
Yeah, a lot of times the facial expressions don't change at all. Sometimes with people that are blind, they may be a little exaggerated, but they have a sense of their face more so probably than we do. In a sense, I mean, if you think about, if you've heard somebody say, well, kind of look with your inner eye, observe yourself. They do that all the time because they don't have visual input from people around them, or because how do we measure what's happening with our face? Usually we're not checking what's going on with our face. We're watching people's reaction to our face. And so for them, they don't have that. And they are monitoring it a fair amount. But you see very similar responses, whether the person's deaf or whether they're blind, with their affective responses. Now, intervening is different because they can't see, like with EMDR. Systematic desensitization can be used pretty well. For somebody who's deaf, you don't have the luxury of reading something to them. So you end up having Braille-based systematic desensitization protocols you walk them through. You need somebody who is fairly adept at communicating with somebody through ASL to be able to communicate with them what they're feeling and experiencing and so forth. So it's a little bit of a wrinkle when it comes to intervention. I think generally it's all the same. It just has to be adapted to the disability the person has. So, all right. So the other one, the behavioral piece, is really the other aspect. We're basically, for first and foremost, we have to assess their skills before we challenge them with them. And in some cases, self-monitoring, self-management, it's not uncommon at all, at least in the work that we do with people that have been traumatized, to ask them to keep a journal of some sort, or a record or a log of what they're experiencing through any given day. I've oftentimes what I've done is that ABCDE model that I used about beliefs. Sometimes I will send them home with that protocol and then ask them to actually fill in the antecedents or the activating event and the belief that they have and so forth. This is all really part of building capacity to go through recovery. And generally we have to be able to know exactly where the person is. What skills do they already have? Sometimes they don't, so we have to build it. That's what social skills training is a good example of. Oftentimes with adolescents, social skills training is basically literally a concrete training method to handle encouragement, to handle affirmation, to handle communicating disappointment. It's really pretty basic stuff. But it is part of interacting and finding resources with people that are part of their lives, and we can do that through the training. The other one is anger control. In a lot of cases, you have people that experience extreme levels of helplessness, and that they really don't have the opportunity to express the rage and anger about what happened to them, and in some cases that needs to be expressed somehow. Whether that's by drawing or whether that's by expressive therapy. In a lot of cases, this is one of those areas where expressive therapy tends to be very useful. When I say expressive, I don't mean expressing. The use of collages and drawings and experience, even things as simple as finger painting. Oftentimes, the sensual aspects of finger painting tends to bring out some other emotions that people oftentimes don't identify, which is ironic. For adults, we've kind of lost our childhood kind of stuff, and having them have the sensory input from doing finger painting or even modeling clay and working with clay during the time that they're going through reporting an incident of some sort tends to diffuse a lot of the emotions that sometimes they have. And just simple training, really, when it comes to anger control and anger management as well. So these are the behavioral aspects of things. We take the affective components, and then we say, now what do we need to do? What kind of skills do we need to develop in the person to be able to manage some of the emotional output that they have? Yeah.
With anger control, could part of that be teaching somebody to actually be okay with being angry about what happened?
Yeah.
And helping them control excessive anger?
Yeah, absolutely. Both ends of the continuum. So somebody who is out of control and needs to learn management of their own emotion, anger. The other one is the person who never has been given permission to have it, and there's a lot of affirmation and validation that has to go into having them express any anger at all. So yeah, absolutely. Did you have a question?
I was just going to say, yeah, you see a lot of people finally express their anger and then just don't know what to do about it.
Yeah, and that's really what we're talking about is working through it, really, is that they do feel guilty because of a lot of social messages about anger and how dangerous it is and so forth. I think in a lot of cases when we're talking about sexual assault, there's a lot of rage and rightful rage that needs to be pointed at the perpetrator, not the victim. And in a lot of cases, there is a blaming the victim thing that happens even with people that have gone through sexual assault with themselves because they're the victim. I had one young lady I worked with for a year and a half. She was a student here, and it took her a good 8 months to accept the fact that she had been victimized. And I knew that I could trigger a fight if I used the word victim in the same sentence with her. She was so angry about it and just would not grasp what that meant. It didn't mean that she had to be a victim the rest of her life, but she was victimized at that point in time, and she was so angry over it that she wouldn't even let the word be used. And it took a lot of time. And when she finally accepted it, her treatment, which was away from me, really took off because she accepted the reality of what happened to her, not the identity of what she was wrestling with, because she tended to see victim as an identity thing rather than an event that actually happened. So, yeah.
Could accepting back on reality or being able to use certain words, would that go along with systematic desensitization?
Say again? Would it go along with what?
Systematic desensitization.
Yeah, sometimes. I mean, oftentimes if they write the story, it makes it real. Then having somebody say the story makes it even more real. And so, yeah, it really is a part of that whole process of being able to identify what's actually happened. Moving on, where we get to next is the cognitive aspects of things. And with some of this we've already talked about when I talked about the ABCDE model with beliefs themselves. But when we're looking at problematic emotions, usually they are very much rooted in mistaken beliefs and errors in thinking. And the key here is not to rush to this one too quickly. I think we tend to want to emphasize the thinking alone part of it and not really incorporate the affective component of it. And some of it is because we're all probably more comfortable with the thought aspect of it than we are with the emotional output. And it can, granted, it can be pretty frightening when somebody gets really upset or starts to kind of lose themselves and their emotions and things like that. The hardest thing to learn, I think, even as a therapist trying to help people, is to not go with them, is to let them be in that place and affirm where they are, who they're with, that they're still safe, and they whatever other emotions seem to come to the surface, to continue to identify that. And that takes some practice. I mean, I don't know very many people that naturally come to when somebody escalates that you de-escalate. And usually, as a therapist, that's oftentimes what you're trying to do. As somebody escalates in their emotions and the intensity that they're feeling things, or the way that they're reporting it, which usually ends up feeling a little bit like pressured speech. It seems like they can't get it out fast enough. You typically, as a therapist, you have to find some way of scaling down rather than going up with them. And that, again, that's one of those things where you tend to get some practice. Usually what therapists a lot of times will do is they will lower their voice as a means of getting themselves de-escalated, so that they're not whispering lower, but there are ways that we can speak where it's slightly quieter and a whole lot more level in tone, that communicates safety, that communicates a calmness. And when people are going through a lot of turmoil and tumultuous kinds of emotions and things like that, if you're able to do something like that, you're providing them with a safe place where they know at least one person is not going to go with them. And in most of the cases in their families and other relationships, either people will get helpless and withdraw, or they'll go with them. They'll escalate with them. And that makes it even worse for them, generally, because then they feel responsible for somebody else feeling bad. And that piles on even more and complicates the picture for them. So you tend to find ways to de-escalate so that you can keep a steady state for them to be able to wander wherever they need to. Once we get out of that emotional state, then we still need to ask some questions about what conclusions are they making, what beliefs do they have about themselves as far as what's happened to them, what other people have said to them that they have kind of incorporated into how they think about themselves. All of those things are part of the cognitive component that we have to unpack somehow. And like I said, go back, review your notes about some of the beliefs, talk about irrational, rational, and rationalizations. You'll hear them all, really, with people that go through it. It's not necessarily your job to identify it for them, but it is your job, if you're going to help somebody, to know where they are in that. So they don't need to know, that they're thinking irrationally. That you might as well club them upside the head. It's better to be able to identify for yourself where they are, so that when it comes time to start challenging some of these beliefs, you know the nature of what they are. And there have been so many times, a lot of people that I've come into contact with where I've developed that ABCD thing, DE thing, and I'll show them that at some point. I won't show it to them initially, but I'll show it to them at some point, and there is literally an audible sigh of relief that they have, that they said, I never, ever thought of my beliefs that way. And now I recognize that I'm catastrophizing something, or I'm trying to rationalize it away. And see, their vocabulary changes, and as their vocabulary changes, how they frame what they're going through changes. And that it's not magic. I'm not saying it is. Just use a different word and everything gets better. No, it doesn't. But it does equip somebody to challenge or look at the beliefs that they hold. Yeah, Kaylee?
Do any of your patients get really mad when you first show them that? No, I don't think that. I'm not doing that. I'm not acting like that. No way. Or do you wait to a point where you think that they've already come to these conclusions and you're just giving them words? Yeah. I mean, if I were to show them that too soon, that would be the reaction.
and I wouldn't show them that soon. I'd be showing it much, much later, where actually I've been using it all along, but I'm not identifying it for them. And so they've made some progress at identifying for themselves the kind of beliefs they have and so forth. And then when we get to toward the end, or toward some point where they feel they've gotten a certain level of mastery, then I'll provide it for them, and then it kind of clicks into place. Because I've been using it all along, now it makes all this sense in the world to them. If you show somebody that too soon, yeah, you'll get defensiveness. You'll get more anxiety a lot of times, because they'll get anxious about catastrophizing, and that's just like a perfect storm for somebody. So yeah, timing is really everything in there. The other one is developmental, which is part of the model we've been using. There are really no specific set of skills here. We really need to developmental. That particular piece of this model is an identification of where the person is. There aren't necessarily skills that we can offer them. Now, if I have a kid who is developmentally in kind of the concrete operational stage from a cognitive intellectual point of view, then I need to adapt my skills to where they are and what they can do. And that's, in that case, the developmental is pretty important. So getting comfortable with a variety of developmental models is helpful for this one. So getting comfortable with Erickson's models of the 8 stages of adult development, so that you have a clear understanding of where this person is. If it's adolescence, then it's inferiority versus identity, and adulthood, guilt versus industry and things like that are a part of those stages. It helps you to identify what kind of skills are needed and how should they be adapted to the person you're talking to. Yeah, Hannah?
I think I answered my own question.
Okay.
But with developmental, where they're at when the trauma happened, or where they're at now that they're
Well, it's both. It really is both. If they're far removed from where they were from when it happened, you have to take both into account. Because in a lot of cases, going back one, in a lot of cases, the false beliefs or perceptions are rooted in the age at which it occurred. And they just carry it along with them into adulthood. So, yeah, you really have to be aware of both of those things. And then finally, the environmental, what kind of community resources you know of, what level of advocacy you need to either be engaged in, or a person that you might need to link the person up with to be able to help them given the situation. We virtually have in the Denver area advocacy centers for virtually anything people will go through, whether that's the Rape Assistance Center, or whether that's workplace trauma, or whether that's school-based trauma, whatever it is. We have some advocacy center somewhere in and around Denver that is really geared toward helping people through some of those things. Yeah.
I'm just wondering what this sort of process would look like for someone who has Down syndrome.
Yeah, I think, in that case, developmental is everything, in terms of cognitively where they're functioning. And the way I'm using the word there is an intellectual functioning level rather than a belief level. Somebody who typically is in the category of Down syndrome is going to have fairly limited cognitive abilities, and you have to adapt whatever skills you use to be able to help them. In often cases, the affective can really run way out ahead because they don't have the cognitive skills to rein it in. And so oftentimes it's all behavioral and a little cognitive, working with people that are less or cognitively disabled in some way or another. And that's usually what you're looking at. a lot of times people that are really pretty skilled at working with disabled individuals, whether it's adults or kids, usually can adapt fairly quickly to how the kid is functioning and how do they understand what happened to them and those sorts of things. It's interesting that with some of the cognitive disabilities, there's a certain insulation from what happens to them. They're still traumatized completely, but they don't think hypothetically into the future as to what their future will look like as a result of what they go through at that point in time. And in a lot of cases, adults do. They not only experience the trauma, but they're also thinking, what effect is this going to have on my relationships in the future and the things that I do in the future. With kids that are cognitively disabled, you don't have that as much, which in a sense makes it a little bit easier in some respects to deal with, because it's fairly contained within what they're experiencing. Yeah, Ashley. Yeah, well, again, developmentally it depends. You have an adolescent. The challenge of adolescence is that they're kind of neither fish nor fowl. They're neither child nor adult, and they have a smattering of thought processes of both. So you can have an early adolescent who's very much childlike, very concrete, not really thinking much about the future, just what's going on, and you can get a middle to late adolescent who's thinking a lot like an adult and thinking hypothetically and future-oriented and so forth. So that's a good example where having an understanding of developmental impact is important to have. So, all right, any other questions on that? Yeah. Yeah.
But what would you say is relevant for friendship
or I think with friendships you got to be fairly careful because you don't really want to play therapist. But I think having some understanding of these things allows you to be aware of resources that you could help a friend get connected to. In some cases, I think you can have, as friends, you can be the active listener, you can ask questions, you can encourage them to ventilate a lot of the emotions they have. If you do that, though, you're going to run into way above your pay grade and you're already, deep in the weeds and you're not sure what to do next. So you have to be pretty careful about what you can and can't do or what your limits are. And I think with friends, even with family members, we tend to blur our resources and we really don't have a real clear understanding of the limits of my resources for somebody. And so, I would much prefer friends not, how do I say this, not enable their friend to avoid help. Because what I've seen in some relationships at least is that the person who's gone through the trauma really doesn't want to talk to a counselor. They're really afraid of a counselor for a lot of reasons, not the least of which is they're not real sure that they'll survive. They'll fall apart, they won't be able to function, etc. And unfortunately, they put their friends in a pretty difficult position because they look to the friend to act like a therapist. And they'll ask them questions that, you really shouldn't be answering. And they'll pick fights and arguments and so forth particularly around theological issues, like how could God let this happen to me kind of thing. And the worst thing that you can do, even as a friend, even worse as a family member, is actually try to create a theology on the fly as to why. I think I may have mentioned this in here, but after my mother-in-law died, we went back to Ohio to be there for the memorial service and so forth. And my father-in-law has never been good on tact. Let's put it that way. And I literally walked in. I was carrying our bags into the house, and his comment to me was, and this guy's almost 90. He's been a Christian for 7, 8 decades. And he said, how can a good God let her be in hospice that long? And thankfully I had enough sense to say, I don't know, take it up with him. And because he was feeling very helpless about his wife of 50 years being gone. And when we get in that place, we tend to want to pick a fight with somebody because we feel so helpless. And I at some level, I knew that wasn't the conversation that Paul needed. What he needed was, how are you doing with the house being so empty? He'd rather talk about theology. And I wasn't going to get drawn into that. I've had fair enough practice knowing how to stay out of those landmines in conversation with him. But I think, you look at my skill set. I have all the abilities, all the experiences necessary to engage that conversation. But I won't do that with family members, and I sure as heck won't do that with friends, because they don't need me to be their counselor. They need me to be their friend or a fellow family member. And that's a limit that I've learned, not easily. Because early in my career, when I was just getting trained, I waded in and did some really stupid stuff, thinking that I was God's gift to my family and all my therapy skills, and it did not go well. And I learned, it was one trial learning. That's all I needed. After that, I was out of it. So I think the limits with friends and family members is really important. And seeing yourself as, I understand this stuff. I got an understanding from the class I went through or whatever. They don't necessarily need to know what you understand, but your questions and your encouragements and your referrals can be seasoned with the information you're getting in a class like this to help somebody like that. So, any other questions? All right. Well, let me go into the other. We'll get started on this one, and then we'll finish it up on Wednesday. And it's the crisis response continuum. Whenever we're talking about the nature of a person's response, we go from what might be called short-term disequilibrium all the way out to more acute, ongoing, debilitating symptoms. And those of you over here, you can't see it. I'm sorry. I'll move it up. And at the front end, a lot of people start out at that short-term disequilibrium, partly because, in a sense, they're ignorance. They don't know what they don't know when they're going through it. Nobody really has a perspective about it. We might have a understanding of it kind of intellectually, but that's really not enough to find our way through. And usually what we're looking at when we're interacting with people that have gone through trauma like this is we're watching this continuum and seeing where the person falls along it in whatever way they do. Some people, depending on their own resources, their own abilities, some of the information that they already have, sometimes all they experience is the short-term disequilibrium. In other cases, it doesn't take much, and it really sends them off into the extreme end. Most of the symptoms we talk about run along this continuum, particularly when it comes to a variety of disorders that show up around stress and crisis or trauma. And that was the new addition. I think I mentioned this to you. Those of you who were in abnormal, you remember this, is that the DSM-5 took a lot of the stress and trauma disorders out of the anxiety disorders and made them a separate category. And that was an attempt to be more refined in our understanding as to how these actually work and what they look like when people are experiencing them. So the one thing that has to be said, and I want to do just a real short soapbox rant for a minute about diagnosis. In general, for most of us, I think we really we can organize our world better with categories. Everybody can. We all do it, okay? And that's particularly true in this area, is that you interact with somebody and you walk away and say, holy cow, that person was really depressed. Well, it's a category. In a very informal way, it's a diagnosis, and we have to be extremely, extremely careful about diagnosis at all, particularly in this area. And one of the main reasons is something called a self-fulfilling prophecy. Our propensity to try to organize our understanding of what's happening to us, if we're just given a label, we think that that's going to help us figure out what to do next or how to deal with life and so on and so forth. And that is rarely the case. And so the reality is that even when we talk about PTSD or ASD, acute stress disorder, or we talk about the various dissociations or dissociative disorders that we were talking about last time, they are never static. They are always on the move. They are always changing. They are always dynamic. And that is particularly true when we're talking about people in crisis. That the diagnosis does not always portray what's going on with them. I have had people sent to me, referred to me, from crisis, a crisis center of some sort. And I get this long list of things that they would fit into as a diagnosis. They're depressed, they're anxious, they're dissociative, they're PTSD, and then add in a little extra sexual confusion, and you got a great martini of crisis. And the reality is, all right, one of the most common ones that I have happen is people that come to me and say they're depressed, and I begin to hear their life story, and they have had 4 or 5 losses through the last 6 months. And they're not depressed. It's called grief. And somebody was bent on giving this person a diagnosis and really shortchanged them on a developmental understanding of life and grieving and loss and what effect it has on us. And so I have and I said this in the abnormal class too, I have a love-hate relationship with the whole concept of diagnosis, because whenever you have to summarize, okay, and that's what a diagnosis is, whenever you have to summarize, you will lose data. You will always lose data. And that's particularly true when you're doing that with people. So when I look at somebody and I say, this person is clinically depressed, that is a shorthand, but it tells me absolutely nothing about the person. The story of their lives, the things that they've gone through, what's contributed to the conclusions they make, all of the history, it tells me absolutely nothing. And in this area of crisis and trauma, we have to be extremely careful when we talk about diagnoses. Because typically, there is more of a threshold than there is a on and off switch. The person's PTSD or not. Nope. It really isn't. It's just like what we were talking about with dissociation, where we go from the very normal, kind of typical dissociative experiences people have, all the way out to the extreme with dissociative disorders. And the same thing is true when we're talking about crisis and trauma. So, just to give you an example, is adjustment disorders. Adjustment disorders was put into the DSM as a means of capturing short-term disequilibrium that people are going through given a particular crisis event or trauma event that they've gone through. There is a 3-month window of response in this regard. So in a lot of cases, somebody who is identified as PTSD may more likely be adjustment disorder with anxious mood, or maybe an adjustment disorder with mixed mood, anxiety, depression, etc. And so there is always a precipitator in an adjustment disorder. You can't just develop an adjustment disorder just from life. Usually there is a precipitant and an identifiable stressor in this case. So we see a variety of things happening, and in a lot of cases with kids, particularly going through crisis, they might look ADHD, because when kids get depressed, a lot of times they look very anxious. Yeah.
I feel like everyone who goes through crisis and trauma or combined
Right.
have adjustment issues, but there are like some cases where someone will go through something like really traumatic and like no adjustment issues. Like they'll go right back into doing things, and is that just a defense mechanism?
Yeah, I would be pretty skeptical if it was a significant level of trauma the person went through and they snap back to normal functioning again. I would be pretty skeptical of that. So yeah, it would be a defense mechanism. It would be in classic Freudian terms, it would be suppression, not repression, because they voluntarily suppress it so they don't experience it at that time. So yeah, I would. I'd be really careful with that one. Adjustment issues is very different than adjustment disorder, because we see kind of an organized syndrome of behavior and emotions that would fit an adjustment disorder, rather than somebody just having trouble adjusting to a new normal, for example.
In high school, there were like a handful of people just throughout the 4 years who would go through something. Like, for example, one of my, not my friends, but a girl in high school, she lost her mom like really tragically. And then it was like she just went to school the next day and was acting like it didn't happen, and people were trying to say sorry, and she was like, "It's okay." And like, but he still has. I mean, I don't know her very well, but still hasn't seemed like it never happened.
Yeah, and even in a case like that, you're never really sure what the nature of her relationship with her mom was like, which also might be part of that. And that, so you end up having to have a little bit deeper field of view to be able to understand how somebody does that. I know for a lot of students that experience a parental loss, it's really tough, because they get a flush of reaction at the front end, and about 3 weeks, it's over. And they're alone again. And that really makes it even worse. Yeah, last question.
This is but as far as situations where people are adjusting to new situations that didn't stem from a crisis or any traumatic event, like coming back to America from the mission field, or adjusting to like a new high school, or like things like that, where it's not a particular event,
right?
But like a progression, would that constitute similar reaction?
It could. I mean, I've certainly had some MKs come back from the field and trying to adjust to the culture in the States has been particularly difficult. And yeah, it's a very clear, identifiable stressor, and adjustment disorder would be the appropriate diagnosis for them. Developmental crises fall in a little bit different category. I think depending on the scenario behavior we see, could be a diagnosis adjustment disorder too. It just depends on the severity level. In a lot of cases, like I said, adjustment disorders tend to anchor that short-term disequilibrium end of the continuum. They may be a little bit up from there, but not ongoing debilitating symptoms or anything. And usually with support and encouragement and a good support system, the person gets back to a reasonable level of functioning within a few months. So, okay, we're done. Bye.